Hi everyone, I'm Mike Putman. I'm at ACR 2024 in Washington, D.C. And today I want to tell you about Abstract 0770, which was one of the plenary sessions on the first Saturday of the morning. Now this was a long-awaited study, and full disclosure, one that I participated in but did not manage to enroll any patients. It investigated the Janus kinase inhibitor Upadacitinib against placebo among patients with relapsing and new onset giant cell arteritis. Most of the patients in the study were actually new onset, about 70%. And all of them were randomized to either receive one of either 15 milligrams upadacitinib, 7.5 milligrams upadacitinib, or placebo. Now, this is a really important question. We have currently one approved medication for giant cell arteritis, and I think we all have been awaiting some of these trials coming down the pipeline to tell us about new mechanisms. So the interesting thing about this study is the people in the placebo group got a 52-week steroid taper, quite a lot of steroids, similar to the prior Giacta study. The people who got upadacitinib all received a 26-week steroid taper. So for me, even if they had held serve, that probably would have been considered a success. What did they find? Even better than that, actually. So at week 52, the rates of sustained remission were 46% in the upadacitinib 15 milligram group versus 29% in the placebo group. So we gave less steroid, and we had a substantially, significantly higher rate of sustained remission at week 52. Now, those results held across many, many other things that they evaluated: FACIT fatigue scores, patient-reported outcome measures, various other ways to assess remission and response in giant cell arteritis. So I would say kind of across the board, it was a successful study and one that I would expect to go on to get approval. Now, there are a couple other things to know. The first is obviously the concern about safety for Janus kinase inhibitors. We have not necessarily seen that with upadacitinib, but we have also not run a study comparable to the oral surveillance study where we saw that risk with tofacitinib. So something that's sort of out there in the ether that makes it a little more challenging. I will tell you, when I have approached patients regarding this medication and said, I think this might work, but there's this potential risk of cardiovascular events and malignancy, folks who are, by definition, over the age of 50 are all quite worried about those things, and it has been a tougher sell than I think you would expect. And then the other problem, and this is a problem that's sort of endemic to the way that we run trials, is that we compared upadacitinib to placebo, which is reasonable. The clinical question here was, does this work at all? The question that I also would like to know as a practicing clinician is this better than the alternatives, namely tocilizumab, perhaps some other conventional synthetic DMARDs? And at this point, we don't really know that. I could see a creative network meta-analysis ferreting that out, but I think in the interim, it'll probably be up to clinician judgment and the particular mix of your patient's comorbidities and preferences. So this is me, Mike Putman, reporting from ACR 2024. Be sure to follow along with all of RheumNow's coverage, and thanks so much for having me.